Yeah, Rob, we are now live on YouTube.
Thank you very much. Tony's handing me stuff here. We will call the meeting to order of the Public Employee Benefit Program. It is December 7th. The meeting is occurring in Carson City, Nevada at PEB's headquarters. I am attending from Las Vegas, Nevada, and I do believe Michelle Kelly is also attending from Las Vegas, Nevada this morning. So we will open the meeting. Please call roll.
Rob?
Here.
Here.
Betsy Ayala? Here. Jim Barnes?
Here.
April Karin? Oh, she's absent, sorry. Leslie Biddleston? Here. Jennifer McClendon? Here. Betsy Strasburg?
Here.
Janelle Woodward?
Here.
And Stacy Weeks?
Here.
Thank you. We have a quorum, and just a friendly reminder to state your name and speak loudly and clearly for our transcriber.
Michelle, I think Chair Rob just dropped off. Can you lead in his absence?
I'm sorry, who's speaking? This is the court reporter. If I can have you state your name before you speak.
This is PEB staff. Michelle Kelly, can you please run the meeting since Chair Rob is unavailable right now? He's having technical issues.
Yes, I can. Michelle Kelly for the record. We've just completed roll call, so moving on to agenda item number 2. This is the opportunity for public comment. Is there any
Michelle,
public comment? Oh, yes.
Sorry, yeah, we don't have any virtual at the moment, so I will get public comment ready for the in-person for those in Carson City. One moment.
Okay, thank you.
Slide up.
If there are folks in Carson City who would like to give public comment, if you could get prepared now and move up to the podium as it becomes available, we would appreciate it. We are limited to 3 minutes per person. So if you could keep your comments to the point. Thank you very much. And Mr. Irvin, I think you're at the podium, so please go ahead when you're ready.
Kent Urban, ERVIN, Nevada Faculty Alliance. I usually have a thing or two to say about the agenda, but today I just want to talk about what's on my mind. Not a good morning. Yesterday, we had a tragic shooting at the UNLV campus. 3 dead, not identified yet, but probably faculty and staff, PEB members. This hits home. Just another mass shooting. It won't even last 24 hours on the news cycle. But we must not become desynthesized. The entire UNLV campus was on lockdown for hours. Then buildings were reportedly aggressively and forcibly evacuated. Our colleague Doug Unger is dealing with that aftermath now. There's a lot of trauma to go around, both for students and staff. Counseling services will be available for students, but sometimes faculty and other employees are just expected to stay strong, Vegas strong. At least we can reach out to colleagues with support. What can PEB do? Acknowledge that members are in pain and communicate about the mental health support services that are available through the program, through Doctor on Demand or otherwise. Back to the agenda. It was frankly hard to decipher the plan design options based on the PowerPoint slides in the board packet. In the past, PEB board chairs have opened up public comment on similar agenda items after the presentation and discussion and before board action. That would be appreciated. Thank you.
Thank you.
Good morning, board. My name is Margaret Kelly Osborne. I am a retired state employee with 30 years of service. In 2019, I contracted COVID. As such, I have stage 4 irreversible lung damage. I'm looking at needing a lung transplant within the next 2 to 3 years. And I'm here to ask the board to please agendize travel appeals for adverse travel. Travel decisions. Presently, you have an appeals process under NAC 287 for adverse determinations for medical issues, but not for travel. The PEB board, our master plan for PEB does not allow for appeals for travel decisions now. But you allow appeals for other adverse decisions. So I'm asking that the board agendize and look into these determinations. So I could spend more than 3 minutes discussing the issue that will potentially put my family into financial bankruptcy while I'm trying to save my life. Right now, you are present. Before, you used to allow for reimbursement of travel, of lodging at GSA rates. So for San Francisco, where the closest center of excellence is, would be $285 a night. Right now, you are allowing $50 a night per person. I had to go to San Francisco 2 weeks ago for my pre-transplant consultation. The cheapest hotel I could stay at was $180 a night. Next door to my hotel was a tent. Next door to the tent was a gentleman with a bucket, and we will leave it at that. When I do have my transplant, one of the major conditions of survival is to stay away from bacteria, to stay away from infections. Putting me in a hotel next to a bucket will have could cause problems. What I'm asking is that you set up an appeals process so I can go over the reason why I feel that your new determination is flawed based on an audit finding that you guys had in September of 2022. That was one audit finding of over 500 audit findings you had. So I feel that this is a knee-jerk reaction to an issue that you guys literally gave 30 seconds attention to in your board meeting in January by looking at the minutes and reviewing the board meeting. I would appreciate if I could have more time to address this life-altering situation if you do put it on your agenda. I thank you for your time. I'm also asking if I could address the board later on this afternoon when you discuss transplant centers of excellence. Thank you for your time.
Thank you for your comment. We will, I will talk to the executive officer about the issues you've raised. Thank you.
Thank you.
Is there any other public comment in Carson City?
Does not look like that, Michelle Kelly.
Okay, thank you. I'm not sure if it's appropriate, but I did just want to take this opportunity regarding the horrendous situation at the UNLV campus and surrounding areas. Yesterday, Mr. Irvin raised the issue of support for employees and students, of course, but on the employee side, I just wanted to let everybody know that NSHE does have an EAP. We have circulated that information yesterday to employees. So if anyone is watching, please utilize the services that are available, and that includes the EAP through NSHE, through CompSky, and then, of course, please, if necessary, your health insurance. So please make sure that you prioritize your mental health and get taken care of. Thank you. Okay, I see Chair Rob is still not connected. So with that, I guess we will move on to the agenda item number 3, which are the board disclosures.
Thank you, Vice Chair Kelly. For the record, this is Radhika Kanal, Deputy Attorney General. This agenda item is to allow me to make a disclosure regarding conflicts of interest on behalf of the board members who are eligible for PEP benefits. Pursuant to NRS 281A.420, on behalf of the board members who are eligible for PEP benefits or whose families are eligible for PEP benefits, I offer this disclosure that they will be voting on those items that may affect the benefits available to them or their family members. The law does not require abstention from voting merely because the board member or their family member is eligible for PEP benefits. At this time, I invite any member of the board who has any additional disclosure to make it now. Thank you.
Okay, not seeing any board members who have any disclosures to add. Thank you for that. We will move on to the consent agenda, which is agenda item number 4. Are there any board members that wanted to pull any of the issues on the consent agenda for conversation?
I do. This is Betsy Aiello, and I would like to pull for just a little item, 4.1 and then 4.2.2.
Great, thank you. Anyone else? Okay, so if we can pull agenda items 4.1 and 4.2.2 from the consent agenda, is there anyone willing to make a motion to approve the consent agenda with 4.1, 4.2.2 removed?
This is Leslie Biddleston for the record. I move to approve the consent agenda with exception of 4.1 and 4.2.2.
Thank you.
Jennifer McClendon, I'll second that.
Wonderful. We have a motion and a second. Is there any discussion? Not seeing any discussion. All those in favor, please say, raise your hand or say aye.
Aye.
Aye. Motion passes unanimously. Thank you very much. Okay, so agenda item 4.1. Ms. Ayala, did you want to take the lead on that conversation?
Sure, and this is just a little technical item, and it's probably been there since we were on Zoom and I never noticed it before. But in the section where it says members present, it says via teleconference, but we're meeting in person now. And so it's just a small little technical thing. And with that correction, I would be willing to say I'd like to move to approve the action minutes unless anyone else has any.
Great, not seeing anyone have any disagreement with that. Is there a second for that motion?
Leslie Biddleston will second.
Great, thank you. All those in favor of passing agenda item 4.1 with the technical correction of changing from video conference to in person? All those in favor?
Aye.
Aye. Aye.
Anyone against? Great, thank you. Motion passes. And agenda item 4.2.2.
And this is Betsy Aiello for the record again. And I would just like to ask if we could have someone with the budget report. Most of the things we'll be dealing with in this meeting are either spending more or saving more money, and to have a fuller understanding of the budget report. And especially because the way it's laid out, it's sometimes hard to understand where we are with excess reserves and along that line also. So if someone could just review it first, that's all I request. Thank you.
Great, thank you. Executive Officer Glover, is someone in Carson City available to review that report?
Yes, I will take that report. Did you have a specific, this is Celestina Glover for the record, sorry. executive officer for the Public Employees Benefits Program. Did you have a specific area you wanted to?
This is Betsy Aiello for the record. When I look at things like realized available funding, it says that the actual as of September this year was 82 million and the year before was 125 million. And I do know we approved a lot of things to spend down some of the excess reserves. But for me to understand, is 82 million good? Is it bad? Is it right on the edge? I can see that there's been a big change in cash. And I know that when you look, we've got catastrophic reserve and HRA, which is things that have to stay. But just to get an understanding of where we are, if we decide to approve more spending later or that kind of thing. How did we do in spending down our excess reserves? What do we have left? A little bit more understanding with that.
So this is Celestina Glover for the record. So the realized funding, that tells us what our actual cash on hand is at that point in time. As long as we're bringing in the cash we need to cover expenditures, then that's essentially what we're looking for. So it's a combination of both what's going out, what's coming in. The reserves, which I know have been a question. So what occurred, the report you're looking at is the end of year for the budget. And then we're looking at that first quarter. When we closed fiscal year 23, there's a reserve amount of $9 million, just over 9 million, or just shy of $10 million. When we balance forward, we're approved for a certain amount in starting cash. In the case of our particular budget, we were approved a little over $144 million to balance forward. We only had 120. So we had a $24 million shortfall. To adjust that, what we had to do was first we look at our reserve categories. We had already received our annual memo from Siegel letting us know what our IBNR and our catastrophic reserves needed to be set at. So we adjusted those first, and they were a little bit lower than they have been in the past. The next thing I looked at is excess reserves. I adjusted that. Well, that took us to 0. So we no longer have those additional funds to apply to any extra benefits or enhancements to benefits like we have in past years. And then once we were done with that, we were still at a point where we were shy by $1.3 million to make that balance forward to be able to open our new year. That adjustment came out of our HRA reserve. That's the next place to go, short of reducing expenditure authority. So that's where we went next. And we still maintain between 65 and 70% of what we see in HRA balances. That's what that reserve does. It covers us in the event that suddenly everybody decided to spend down whatever was in their balances. So our starting cash is 120 million versus 144. And then any other revenue we bring in, which comes through employer contributions, employees contributions, are rebates from medical or from, pharmacy, and treasurer's interest, that makes up the rest of our revenue for the year. And then we monitor that through the year to make sure that anything that we need to spend, so that our primary focus is going to be claims, make sure that we have the cash that we can cover those claims. If for some reason we have a shortfall, then we will go to our reserves, either catastrophic or the incurred but not realized reserves, to address those shortfalls, because that's what they're there for.
So this is Betsy Aiello. And a follow-up then, what I think I heard was that we came in with a shortfall, but we were able to make it up with some reserves. So when we're looking at new spending or savings, we did come in with a shortfall. But this may sound crazy, but I think a little bit with PEB and my background with Medicaid, 1 million is not very much. So it may sound strange, but it really isn't much. And so we're pretty much even right now. Not a lot of extra money to spend, but not having to try to generate a lot of extra money would be my assessment from what I heard, maybe.
This is Celestina Glover for the record. You're correct. The $1 million is nowhere near. That's a day worth of claims. I mean, that's obviously not gonna help us a lot. Right now, we have what we need to cover current expenditures. And we'll continue to monitor that as we always do the quarterly projections.
And then one more follow-up question. Sorry, this is Betsy Aiello again. So let's say something really strange happens and we get a little bit partway through the year, because I know we set contribution levels, we set rates, everything. The reserves are the only way, and that's part of the reason why there is a catastrophic reserve, would be my guess, to make up any shortfalls that may occur in a next quarter or a next quarter.
Correct. This is Celestina Glover for the record. That's correct. We will go to catastrophic reserves first if we should have a shortfall. Typically, we would go to the excess or the differential cash. We would go there first. We don't have that. So our next place would be to go to catastrophic reserves if we had a shortfall, and if for some reason we expended that entire reserve, then we would go to our IBNR and HRA. It would depend on what's generating the shortfall.
Thank you.
You're welcome.
I don't know if anyone else has any other questions.
Stacy Weeks for the record. So it sounds like, I'm just making sure I'm following, there's projected spending. And so I think going off of that, if we're making decisions today for add-ons, how much do you feel like, can we only add 1 or 2? Like, what is your recommendation around that in terms of how much we have to spend? Or is that a question for later?
This is Celestina Glover for the record, kind of a combination. It depends on what you approve. Obviously, what we're showing in our plan design recommendations is a combination of savings and expenditures. So it really depends on how high. And then once we start the rate setting process, we'll bring rates back in March. That's going to determine really, what the plan is going to cost at that point. So they'll start analyzing that. Siegel is our consultant. They'll start analyzing that as soon as they're aware of what's been approved and what has not. And then we will look at what our experience is looking like for the last year and current year, and then rates will be set accordingly. If it looks like rates are gonna, blow up and we can't do these things, then we'll bring it back.
Great. With Chair Rob's permission, I'll finish out this item and hand back the gavel to him. So with that, is there any other board member comments or questions on the budget report, agenda item 4.2.2? Not seeing that, I'll accept a motion if someone would like to make
I'll
it.
move. It's Betsy Aiello. I'll move that we approve the budget report.
Thanks, Betsy. Second.
Second, Betsy Strasburg.
Thank you, Betsy. All right. Any discussion on that item? Nope. All those in favour of approving budget report 4.2.2, please raise your hand or say aye.
Aye.
Is there anyone in dissent? Nope. Motion passes unanimously. Thank you very much. And back to you, Chair Rob. We're up to agenda item 5.
Okay, thank you very much. Appreciate that. I apologize for the technical difficulties down here in Southern Nevada. We should be good now. Discussion of possible action. Number 5, discussion of possible action regarding a proposed contract with Current Health to maintain a network of national centers of excellence. A portion of this item may be conducted in closed session to allow review of results of evaluation of proposals for contract in accordance with NRS 287.04345, Section 4. Any action on the contract will occur in open session in accordance with NRS 287-04-345, Section 5. Michelle Wayland, Chief Financial Officer, how do you want to proceed from here? And going into closed session, what do we need to do in public before we go to closed session?
Michelle Whalen, for the record, we would like to go into closed session and allow purchasing to do their presentation.
Okay, we will go into closed session. Closed session will be done for those participating electronically on the Teams channel that was sent. So we will close out this agenda item. We will keep this live. I will mute and turn off my camera. Please, if you're participating remotely, do the same. And we will switch over to the Teams channel, is what I understand. Okay, thank you very much.
We will need somebody from the board to make a motion. If I may jump in, this is Radhika Kunal, Deputy Attorney General.
It's Michelle Kelly
Okay.
for the record. I make a motion that we close the public meeting and go to Teams for a closed room discussion on the contracts.
We have a motion. Do we have a second?
It's Betsy Aiello, I'll second.
Okay, we have a motion and a second. Any further discussion? Seeing none, I'll call for the vote. All those in favor of going into closed session, please signify by saying aye. Aye.
Aye.
All those opposed? Okay, we will go to closed session. Thank you very much.
Excuse me, if I
Yes.
may.
Yes?
May I ask when I could give public comment before, about this agenda item?
This is Celestina Glover. There is not a specific public comment to this agenda item. We will have another public comment at the end.
Could I ask to be, I understood that I could ask to be, to make a public comment on an agenda item. Any items at the end of the meeting? Okay, thank you. I'm not aware of the
Insurance
process.
counsel, in the chair's discretion, he can allow public comment on individual items.
This is Jack Robb. Public comment was agendized, agenda item number 2. But to be open and transparent, I believe it's at the discretion of the chair if we allow some public comment. I would rather err on the side of caution. And if somebody does want to make public comment on this item, I will allow public comment on this item prior to a vote occurring. But at this point, we do have a motion and seconded, and a motion is passed. We're going to go to closed session, so we will ask all those not participating in closed session to exit the room, and then we will come back into an open session. And prior to any vote being cast, I will allow a member of the public to voice their concerns or have any public comment on this item prior to an action being taken.
Thank you.
Okay, so we are in closed session.
Chair Rob, I'm going to be the PEB boardroom is going to drop off the Zoom meeting on YouTube. I'm going to continue live streaming it, but with a closed session slide, and our estimated return time will be 10 a.m.
Thank you very much. So we will plan on returning at 10 a.m.
Prior auth, this is Joanne. How can I help you? Yes, hi. How can I help you?
Okay, I see it is 10:25. Okay, I'd like to call the PEB board meeting back to order. We are still on agenda item number 5. And I think everybody that participated in okay. We're on agenda item 5. I'd like to call the meeting back to order. I believe everybody that participated in a closed session does understand what motions need to be taken one way or the other, so I will call for a motion.
Public comment?
Okay.
This is Tina. Jack, did you want to do public comment before that or after that?
I apologize. I did say we would take public comment, so thank you for reminding me. I forgot about that. I noted it and didn't look at my own notes. So let's go to public comment.
Thank you for hearing me out again. My name is Kelly Osborne, P-E-L-L-Y, Osborne, O-S-B-O-R-N-E. I just wanted to address the board again, if I may, about transplant issues at Centers of Excellence. I don't know what you guys discussed in this contract negotiations, but I am currently under consideration for transplant at UCSF in San Francisco, which is a center of excellence. It's the closest transplant center to our location. It's 220 miles away. A 6-month process, to be considered for transplant, to be tested for transplant, to receive the transplant, and then follow-up care. So I just ask that you all take that into consideration when making this decision, to see a face, to see a person when you're making these decisions. I have felt that I have, during this process in dealing with staff members with PEB, that I that my concerns have been addressed, that I have been put on the back burner, that it's blasé. When the board made the initial decision about this Center of Excellence and travel decisions, they liked it with bariatric surgeries and with a 3-second mention to transplants and things like that. That's how you guys were addressed when it came to transplants, life-altering decisions. I'd just like you to know that I'm a person. My life depends on this. I have education for you all about what's required of a lung transplant, of me and of my family, and my duty to my donor. I appreciate your time. I'll leave these here for you all. I don't know if I'm allowed to pass them out, but I'll leave them here for you all to take. Thank you for your time.
Thank you very much. I appreciate that comment. And do we have any other public comment, either online or in person in Carson City?
No public comment, Chair Bob.
Okay, thank you very much. I will bring it back to the board for a motion.
Stacey Weeks, I move. Make a motion to continue.
This is Leslie
Nice.
Biddleston, I'll second.
Okay, we have a motion and a second. Any further discussion? Seeing none, I'll call for the vote. All those in favor signify by saying aye.
Aye.
Aye. All those opposed? Motion passes. Thank you very much. We'll move on to agenda item number 6, Executive Officer Reports. Celestina Glover, Executive Officer, Information and Discussion. Thank you.
Thank you. This is Celestina Glover, Executive Officer of PEB. The report this meeting is fairly short. I just wanted to let the board know that we are finally starting to fill some of our vacant positions. So our vacancy rate is down to that's at 21%. We're still, we have 7 positions vacant. We just interviewed for one in the accounting unit. The person has accepted, but they haven't come on board yet. Another week, two weeks. So that'll give us 6 vacancies. Majority of them are on the operations side of the house in our member services unit, and they are working toward recruitment there to attempt to get those positions filled. The other item is the interim retirement and benefits committee. Right now, that meeting is scheduled for the 16th of January in Las Vegas. Right now, we have submitted our report. It's been posted. LCB posts those reports. We will follow up with whatever approvals the board does for plan design after this meeting, and anything else that LCB might need us to add for the committee meeting. There's nothing that I'm seeing right now that's cause for concern. This meeting happens routinely, and both PEB and PERS present. The plan is for Michelle Whalen and I to travel to Las Vegas to attend the meeting in person versus going virtual. And with that, any questions?
Okay. Seeing no questions, we will move on to agenda item number 7, discussion of possible action for plan design changes for plan year 2025, July 1st, 2024 through June 30th, 2025. Celestina Glover, Executive Officer for possible action. I do believe we need to move on to 7.1 first to discuss those potential plan changes, and then we'll go back to agenda item 7 for a vote. So 7.1 potential plan changes, please proceed.
So this is Celestina Glover. So just to tee it up, this is a follow-up on the last board meeting where we presented some ideas for analysis and consideration, and we've had that done. We're bringing those ideas back. Siegel, Richard Ward will walk us through the analysis and the results, and then when we come back to this agenda item, we will discuss and the vote. And with that, I'll hand it over to Richard.
All right, thank you. Our materials, the Richard Ward for the record, our materials start on page 196 of the PDF, just to round everybody. And what we have is a review of the items that the board approved at the prior meeting for further investigation and consideration and analysis. The first one is open access pharmacy is how we're characterizing it. So that would be to provide access to additional pharmacies than is currently available in the Express Advantage and Smart 90 networks that were implemented in plan year 22. On page 197 of the PDF, this is a bit of a reset slide. This is identical to materials from the prior board meeting. Just why is this worth considering and what are some of the next steps? So currently members utilize a narrow pharmacy network or narrow networks for retail prescriptions for retail pharmacies. There is an option to provide broader access, and the next steps were to review the additional access and any cost or savings for the plan and for members that might result from that change. So we're back here to review that. Results of the analysis is that there'd be a minimal change in access, by broadening the network. It would add either CVS or Walgreens, which are available in more populated areas where there are already other pharmacies. So members have access in those areas, already have access generally. About 99% plus members have access to network pharmacies. And broadening that access would erode the discounts available and would lead to higher costs for both the plan and for the member. And in conjunction with Express Scripts, we developed some estimates that would be for the plan, $625,000 to $900,000 annually for expanding both the retail 30 networks. And then because there's a member cost sharing component to the total cost of the medications, that would lead to higher member costs also, primarily in the CDH plan of about $330,000 to $440,000. So to summarize, access would be largely unaffected. It's very broad now, and it would lead to higher costs for both the plan and the members. Moving on to the specialty drug cost share, specialty copay. I'm on page 199 of the PDF of the board packet. Right now, for members that are on specialty medications, the plan has a 20% after deductible cost share in the CDH plan and in the EPO and the HMO, and 30% after deductible in the low deductible health plan. So the consideration here is to reduce the cost share exposure for members that are on these medications. And for members that are on these medications, some of these drugs are on the Save On SP drug list, which means that they're eligible for manufacturer coupons, are on a drug that is eligible for manufacturer coupons, and they enroll in the Save On SP program, then their cost share, let's just use the low deductible health plan to illustrate this, would go from 30% to 0. If they're on a medication that is not eligible for a manufacturer coupon or is not eligible for participation in the Save On SP program, then they have that 30% cost share. And as we know, a number of these drugs are high cost. There's an example at the bottom that if a member has a $10,000 medication, then their exposure is $3,000. And so the consideration is there a way to manage or minimize that exposure to the members, and what is the cost to the plan for doing so? Options are developed. So first of all, if in both options, and I'm on page 200 of the PDF, if a member has a medication that is on the Save On SP drug list, then the coinsurance as it stands, as is currently constructed, still applies. And that's important because it provides the member an incentive to enroll in the program. The member has no cost share as a result, and then the plan gets savings from the coupon. So it is a win-win situation, and having the current cost share in place provides an incentive for members to participate. The two options are for members that are on medications that are not on the Save on SP drug list. Option one is to apply the benefits for tier 1, tier 2, and tier 3 medications. So for non-specialty medications to the specialty, and that's shown in the table at the page 200 in the EPO and the low deductible health plan. $10 copay, $40 copay, $70 copay, depending on what tier that specialty medication would fall into. Primarily, it would be tier 3, I would expect, but there'd be a $70 copay, which is lower exposure than a lot of members have currently. And if they're in the high deductible health plan, then it's % after the annual deductible. Option 2 is to continue to apply the 30% coinsurance, but with a minimum and a maximum. So it would still be the 30% coinsurance, but it would, in the example on the prior page, instead of it being $3,000, the member would be capped at $250. And in conjunction with Express Scripts, we've analyzed the cost impact of those two options. They are both cost increases. I want to be clear there, but is a cost shift from the member to the plan, and that's $50,000 on an annual basis for option 1 and $20,000 for option 2. And one of the reasons that it's more moderate than you might think, because there are a number of people on these medications and they are high cost medications, is that the current cost share leads to the vast majority of these members hitting the annual maximum out of pocket. And their situations, their overall medical situations and their care needs would still result in their hitting the maximum out of pocket, the annual maximum out of pocket, even with this change. So it provides, I think, while it may not affect the overall out of pocket for the members or the plan, it does result in members not needing to pay that full $3,000 in that prior example earlier in the year, and it spreads out their costs during the year. I think that's a kind of a non-financial consideration here. Okay, moving on. Another consideration is the medical pharmacy coupon program. So this is a new program that UMR has available beginning January of 2024. It will be implemented here in PEB July of 2024. And it's a program that is very similar to the Save on SP program in nature, except that of drug manufacturer coupons that are already available, except that it applies to a different set of medications. So the Save on SP program that Express Scripts has is for patient medications. The UMR program is available for inpatient. So there's drugs that run through the medical claims component of the program. And currently, if there are drug manufacturer coupons available, there's no mechanism to access the value of those programs to benefit the plan or the member. This program does that. So mechanically, it works in a similar manner, in that it's a list of medications where there are coupons available. UMR maintains that list. When a member is prescribed one of those medications, then there's outreach to the member to enroll them into the program, and then the value of the coupon is used to the benefit of both the plan and the member. So when we reviewed this slide here on page 2 of, getting ahead of myself. The next steps were to review the program details with UMR and then to review the member impact. plan savings that may be available. Moving on to page 202, there's a review of the program. So it's the name of the program is the Copay Maximizer Program. Patient advocate will handle the member outreach and provide support to enroll in the program. And participation is voluntary, and it can be added or removed. So a member can opt out if there's a component of the program that they don't care for. The member receives the medications with, in most cases, zero cost share. In the case where there may be cost share, it's lower cost share than there is now. And the amounts similar to the outpatient program, the copay assistant amounts or the coupon values are excluded from out-of-pocket accumulators. So that maximizes the benefit to the plan. UMR does retain 30% of the savings. It's estimated the plan would save about $700,000 a year. So there's about $1 million gross savings and then net of that 30%. Some detail here. Some questions. UMR's analysis indicates that there's about 150 members that are on medications that would be eligible for this program. And so these are also very high cost situations or medications. And so it's a relatively small number of people that enrolling in this program and then accessing the value of those coupons can benefit both the members and the plans in a fairly material manner. Page 203, so I'm using page and slide interchangeably. Page 203 has an illustrative example of how this works. And bottom right corner, these are materials provided by UMR as an example. So without copay assistance currently, with this example, with a $4,000 medication and a $2,500 per claim, also using coupon and copay assistance interchange. Apologize for that. The coinsurance would be $800, and that's what the member would pay. The member would pay $800, or it'd be applied to deductibles and depending on them where they are with their max out of pocket. But that's a member share, and the plan is $3,200. With the program, start off with calculating the coinsurance as $800. The copay card or the coupon would absorb 35 of that, reducing the member cost share to $25. And the employer cost, excuse me, then this is without the program. So the member would receive $775 in cost share relief of the 800 down to $25, and there's no benefit to the plan. The plan still pays $3,200. With the program in the far right, the full value of the card or the coupon is applied to cost and reduces the plan cost down to about $1,500. So in this instance, there's a reduction of, just making the math round here, about $1,700 in this particular instance, just looking down at the bottom and following the line across. I know it says employer, but it's really PEB is a plan, so it's to the plan. And the member costs are reduced by $775. So they're paying the members paying $25 instead of $800. So savings to both parties. And this is comparable to how the Save On SP program works. It doesn't, the math isn't exactly the same, but the concept is the same. Okay, moving on. Page 204. At the prior meeting, there was discussion between the EPO and the HMO and exploring some alternative options and ongoing viability of the HMO and the EPO and HMO as a combined plan offering or a consolidated blended. This was in anticipation of a 20% increase with the HMO renewal. Experience had been indicating that the renewal would be capped at the 20% cap. Prior years had been capped at 9.5%, but for for plan year 25, that cap was increasing from 9.5% to 20%. And the loss ratio and claims experience was indicating that that's where the renewal would come in. So we talked about exploring some beginnings to evaluate some potential alternative scenarios and wanting to be cost impact, benefit value, risk distribution between the whatever plans were in place in future years. So since then, and we have a review. This is, I think, at this point, mostly an FYI. At the prior meeting, there was some discussion about current plan benefits as well as the actuarial value for the plans. So on page 205, we have a summary here of the deductibles and out-of-pocket maximums, coinsurance, and office visit, cost share, co-pays, or coinsurance, depending for the different plans and for all 4 plans, and then the actuarial value in the top row. I think more germane for right now is to review for all of us, we're anticipating a 20% renewal, which would be a sizable increase in the HMO plans. And then therefore, because the HMO and the EPO are blended together, it'd be a sizable impact on the rates, those blended rates. Well, we have good news. The renewal came in at 12% rather than 20%. And on page 206, we have a comparison of what was expected. So the first row is the calculated renewal action. So about 29% is what the claims would support. And if that had been the case, then the HMO premium would have been $13.55. It is currently $12.20. Sizable increase. With the renewal cap, with the cap increase, it'd be $12.63. However, with the 12% increase, it's $11.80, and I misspoke. It is not $12.20. The blended is $10.85 currently. So that's a net difference. I hesitate to use the word savings, but it's a net difference from what was expected of $83, which translates to about $3.5 million annually. So that is the Tina, do you want to talk to that or can I can? Okay, so the option on the table for plan year 24, plan year 25, excuse me, is to accept the renewal and then continue to explore potential alternatives for future years so that if experience continues on a elevated path, that there's thought and consideration put into alternative approaches over a time period. Okay, then last one here that we're gonna talk about is Health Parity and Addiction Equality Act compliance. At this meeting a year ago, the board directed PEB to opt out of compliance with mental health parity. And that was an option that at the time was available to non-federal governmental plans and employers. And the intent was not to be out of compliance, but the intent was to provide benefits that are on parity between medical, surgical, and mental health substance use disorder benefits. But the benefit of opting out was to avoid the possibility of a federal audit, which we've had some clients that have been audited by the feds, and it is an extensive, time-intensive, intrusive process. Part of the decision and the direction from the board at that meeting was for Siegel to perform a parity compliance review and to come back a year later and with the results of that. So we're here. Something that has happened that was unanticipated at the prior board meeting is that about 2 weeks after that board meeting, the federal omnibus bill eliminated the opportunity for public plans to opt out of compliance. So you no longer have the opportunity or the option to opt out. So it really became more necessary for us for a compliance review. So we've done that. And we're gonna, I think, speak in more detail and more specifics at the January board meeting, but there is one item that some consideration today. But let me talk a little bit just about the review process. And the review process is not something that Siegel has determined. Really, we're following the guidelines, the statutory guidelines and the regulations on how this review needs to be performed. There are two main components to this review. There's the quantitative treatment limits, QTL, is probably the term I'll use, and non-quantitative treatment limits, NQTL. The quantitative are essentially the cost sharing measures. Are the deductibles, are the co-pays, or the maximum out of pockets, co-insurance, are those provided with parity between medical, surgical, and mental health and substance use disorder benefits. And then you have NQTL, which are, say, more softer components of the benefit program. So those could be prior auths or some benefit exclusions or coverage exclusions that maybe don't show up in the open enrollment guide. And so we've reviewed from both aspects, and within the QTL, we look at, or we're required to look at some specific coverage categories. You have inpatient, outpatient office visits, and then you have outpatient other services. So that would be diagnostic, and maybe if there's an outpatient facility. And then you look at those three for in-network and out-of-network. And for each of those categories, you look at the benefits that are provided for medical surgical, And there's very specific parameters on how you determine what is called the predominant financial requirement. So what is it? Is it primarily deductible and coinsurance? Is it copay? You review the medical and surgical benefits and reach that conclusion, and then you what is provided for mental health and substance use disorder. The CDHP plan, primarily because it's deductible and coinsurance, is fine. So set that aside, there are no issues there. For the low deductible health plan and the EPO, everything is fine for QTL, except for other outpatient services for network benefits. Out of network is fine because that's also a deductible or coinsurance provision across the board, and it's the same. For the low deductible health plan and the EPO, there's a mix of deductibles, copays, and coinsurances that apply for medical surgical, for outpatient surgery facility, for diagnostic tests, diagnostic imaging. And because there's this mix of cost structure, there is no predominant financial requirement. And so our recommendation to ensure compliance is to update the benefit provisions for either or both medical, surgical, and mental health substance use disorder benefits. And there's a couple of options that we've developed that are on page 207. And option one is to add copays to the medical surgical benefit so that there are copays for both types of benefits across the board. And since that would add copays that aren't there currently, there's some savings involved, and that is really a cost shift from the plan to the member, if that's the option. Option two is to add copays and change some of the coinsurances from 100% to 80%, so that all the coinsurances are 80% on the medical surgical. And because that increases the coinsurance, there's less of a savings there. For three is maybe the most complicated. You're making changes on both. As it turns out, is about comparable from a cost, from a savings perspective for option three. And then option four, which is maybe the most straightforward, is to remove a copay from mental health substance use disorder that doesn't exist, that isn't present for medical surgical benefits. So the issue is there's a copay on mental health substance use disorder that is not in the benefit, that is not present for medical surgical, and that creates an imbalance. So if you remove that copay, then you have alignment and you have parity. And that comes with a bit of an increase in costs. 300,000 to 400,000 is our estimate within the context of about a $360 million annual spend. Moving on to page 208. For the NQTL, again, the non-quantitative treatment. This is a review of exclusions, prior auths, maybe just some language clarifications in the plan documents, updating some key terms and definitions. Generally, things that we've identified that could be characterized as cleanup, that should not have a financial impact, should not affect member out-of-pocket costs. We're still working through that detail with PEB, and similar to the compliance review that we performed last year, the anticipation is we'll be here in January for more detailed discussion and review of that part of the analysis. And then the last slide here, page 209, has just a summary of each of these options for the open access pharmacy, specialty copay change, the UMR RX coupon program, the HMO renewal for plan year 25, and then the mental health parity compliance options. There for discussion or questions?
This is Stacy Weeks. On that last slide, can you, on the third one there, the coupon program, I know it says 1 million, but we're really only able to keep what, 700,000 of that? Because don't we have to give 30% of that?
That's
savings
correct. So
back
it's
to them?
700,000.
So it's really 700,000. Okay.
Oh yeah, I'm sorry. That was a after the ink was yeah, that was a last minute clarification on the value of that to net out the added. I apologize for that. Thank you for noting that.
Okay, any further discussion or questions?
I'm sorry.
No, you go.
Jennifer McClendon for the record. I have a question about the open access pharmacy. I think this is a question for PEB. I just remember hearing a lot of grumbling when we switched to the plan that didn't allow CVS and Walgreens. I'm imagining that people who are on like long-term medications have made the switch at this point. But do you get a lot of claims that you don't pay, or like, is that still an issue? Because let's say I take my child to the pediatrician, my child needs an antibiotic. I don't know that the change has happened because no one in my family is on a long-term thing. We're getting a lot of feedback from people that that is still very frustrating for them. Do you sense there would be a value of going back? I just don't know what the user experience is.
So this is Celestina Glover for the record. I'll let Tim answer about appeals regarding claim denials, but I would say based on the analysis of my discussion with Siegel, that if we went to this more open network at this higher cost to both the members and the plan, it really doesn't provide as much of a benefit as we were hoping, because exactly what you said. People have already made that change, so the likelihood is they're not going to change again. I personally haven't heard a lot of comments. I know from personal experience, you know, I've had to have an antibiotic myself, and I just go to Walmart and get the thing and move on. I don't even really think about it because, you know, I know that is one of the places I can go. But I haven't seen a lot. I don't know if Tim has received a lot of appeals in the last year since we've changed this.
Tim Lindley for the record. We do get some member questions, and I think it ties down to education because of the narrow network. And what typically happens is a member will get a reoccurring medication, go to CVS or Walgreens, and the price jumps after the first 2 bills, where there's penalties involved or paying the actual cost of the medication, or it's the lower of the 2. And then it's steerage to the save-on pharmacies, and that's the most common thing that we see. And once that steerage happens, it tends to resolve itself at that point. But I don't see very high complaints or appeals for that.
Any further questions? Ms. Aiello?
This is Betsy Aiello, for the record, and I have a question regarding the medical pharmacy coupon program and how it actually works, because it says copay assistance without the maximizer, the coinsurance is $800, and with the program, the coinsurance is $2,525. And I understand that if the card only requires you to pay $25, if you raise the coinsurance, then the card's going to pay more.
Right.
So we don't have to pay more. But does that mean we make a plan change where coinsurance and inpatient is higher?
Yes.
And would every one of the drugs then, or will someone get stuck with a higher, if there isn't a card, a higher co-insurance amount than they would have.
So very, very important distinction here, and I'm glad you're asking that because I apologize that I wasn't clear about that. It would work in a way that the elevated co-insurance only applies if they're on a medication that is eligible for the program.
So that's how the plan document would be.
Right. Okay. I'm here speaking on behalf of their program, so I want to make
Okay.
sure that the answer is accurate. So
That's a big jump.
it
really.
is, yes. So it would operate similarly to how the proposed change would work for the Express Scripts program.
And currently, without the program, the employer cost is higher, but the member pays 25 if the coinsurance, if it says without the program, coinsurance 800, copay card 775. So that says with today, so that must happen today.
And that's if the member that's if the member on their own goes and gets a coupon.
On their own does it?
Right,
Knows
right.
to
So-
do that just
so it's-
automatically.
Correct. So
Okay.
it would happen on a limited basis, I would expect.
And with the program, UMR is doing it.
That's right.
Okay, that makes a difference, because I was gonna say the cost accumulator goes down a lot, but there's probably very few members that know to get this coupon themselves. Unless, I don't know who would be telling them, the pharmacist, an inpatient, or. who-
Yeah, they may find out from a provider.
Okay,
They might, but I would expect
That's-
utilization to be very low.
is that good RX that sits at every provider?
No,
That's outpatient.
that is outpatient, and that is to evaluate cost differences that are available between different pharmacies, essentially.
Okay,
So this is a coupon available from the drug manufacturer.
that someone would have to figure out, yeah, and.
They'd have
so-
to enroll in the manufacturer's program themselves.
I'm sorry, this is the court reporter. Can you guys speak one at a time, please? You're stepping on each other's words. Thank you.
Okay, sorry, I'm good at that.
Okay,
Me too, we're a good team. That was Richard Ward for the record.
okay, Board Member Weeks.
Thank you, Chair Rob. I just have a couple questions. So the first one, I just want to say, really nice job on getting the 3.5 million. I'm guessing that was some good negotiation, so thank you. That's nice to see. I think that would have been a bigger ticket item, and I think it gives us room. So when I look at the coupon program, the 30% admin spend in my world is super high. Is there any room to go down there so we get more money back? Even 25% or even 15 or 20. I mean, 30% admin cost for the coupon program feels a little high in my mind. So that's my first question. My second question is compliance with parity. When I'm looking at this listed, so I'm looking at option 3. Is that essentially saying we would really say to for our medical spend and co-pays, we're keeping people, holding them harmless, and we're bringing mental health up to be kind of equal with that? We're not punishing on the medical side to make it equal for behavioral health. We're sort of equalizing on option 3. Am I reading that correctly? And that's all I have. Thank you.
I would have to, regarding negotiating the 30%, I'd have to defer to UMR to comment on that.
Okay.
I do know that this is a program that they now have through an acquisition. So the program is already in operation with another TPA that they purchased. And perhaps there's more flexibility in the cost structure going forward after it's been, it hasn't even gone live yet with any of their customers. So.
Stacy Weeks for the record. Well, what I've learned, if you don't ask and you don't push, you're never going to get a good deal for the state. So I think we should push if we can.
It would have to be a senior leadership decision.
Okay. Well, Stacy Weeks
We
for
can
the record.
certainly ask.
Stacy Weeks for the record. Yeah, that would be good to know. And if you could ask, thank you. And then again, on the mental health, on the option 3, is that correct to say that we'd really be just bringing mental health up to where medical is and co-insurance and kind of equalizing? Or
No, actually, there are some co-insurance, so outpatient surgery facility for medical surgical is 100% after a $500 copay. And so that would be reduced to 80%. Other outpatient services for mental health and substance use disorder is at 100% after a copay. So that would be at 80%. Diagnostic tests are at 80%, that would be unchanged. Diagnostic imaging, also medical surgical, is currently 80%, so that would be unchanged. Back to mental health and substance use disorder, partial hospitalization is at 80%, so that would be unchanged. And then intensive outpatient treatment is 100% after a copay, that would be reduced to 80%. So there would be increased cost share on both.
Stacy Weeks for the record. Is there any way, and I'm sure you've done all of the back and forth, is there any way though to, because I think about IOP, like that's an important one and I'd hate to see us lose. I mean, behavioral health is a huge challenge across our state and I'd hate to see mental health lose on this at the same time medical as well. So I know you've tried to find a sweet spot, but I don't know, is there a sweet spot here? Or is this just really reality? We're just gonna do 80% across the board and be like, okay, well, this is like the safest way to do this and be in compliance and know that we may see some losses for people in terms of cost.
Are you asking what our suggestion is?
Yes, I am.
Option 4 is our suggestion.
Option 4, okay, the cost.
Which remove, so right now on outpatient, so for the mental health substance use disorder, there's a $30 copay for other outpatient services. Again, this is not office visits. And for intensive outpatient treatment, there's a $30 copay. Option 4 removes those copays and care is available at 100% as a result. And so there's a cost increase associated with that. Look back to my screen here, $300,000 to $400,000 annually, which is about 0.1%. Pains me to say this, but our trend assumption is going to be wrong by more than that. So it's a relatively minor cost impact, in my opinion. That's for that's open to other considerations, I suppose. And that's, I think, a clean change. It's relatively easy to communicate. It's a change to the mental health substance use disorder benefits to become compliant with mental health parity. So that I think there's an alignment there as well. But that's our opinion.
Stacy Weeks for the record, thank you for that. Yes, it seems that helps me understand because I was reading option 3 and wrong apparently. And what I hear you saying is we pay a little bit to get sort of do no harm and also maybe even improve access.
Yes.
And that's a
yes.
win. Okay, thank you.
And if I may, just additional clarification, I don't know if it's necessary or not, but the office visit copays would be unchanged. This is for other outpatient. So the overall utilization and volume is relatively low compared to even other mental health and substance use disorder care.
Okay, Board Member Kelly, do you have a question?
Yes, thank you, Chair Rob. Michelle Kelly for the record, Kelley. I actually have maybe 4 questions some of them are just clarification, so I promise to be quick. Firstly, I wanted to start out at the specialty drug program as outlined on this, and I think it is just a clarification question. Between the Save On program, I know I'm getting the name, the Save On SP Drugs program and the non-Save On SP Drugs program, if we implemented, say, option 1 or option 2 that are outlined here, could there ever be a case where the Save On SP Drugs, someone who's using that program, has a co-insurance payment greater than 0? Because I think I did hear you say that if they're on that program, there's 0 copay. But I just want clarification that that is true. So if you are participating on the Save On SP Drugs program that's currently in place, you would have a zero copayment.
That is correct.
Great, thank you. And then what percentage of drugs are available on the Save On SP drugs program that currently exists? Do we know that?
You mean Richard Ward here. You mean as a percentage of specialty medications?
Yes.
There are currently there are about 600 members that are enrolled in the program. That's here.
Okay, but we don't know what percentage of drugs, specialty drugs, are available on that program.
The list changes from time to time. I'm gonna phone a friend here and ask Express Scripts to comment on how broadly applicable or available what percentage of specialty medications are on the Save On SP drug list, roughly?
So, hi, I'm Nancy Langland for the record. Thank you. So I would like to confirm what percentage is offline and circle back with you. What I can tell you is that the drug list does change 2 times a year, typically in January and July. We could potentially see changes. It's not a guarantee that there would be changes, but we can have changes up to 2 times a year.
Okay, and so no one has a rough percentage of what, is it 40%? Is it 20%, 60%? No one can provide kind of a ballpark?
If we're allowed to speak more broadly, I'd say it would be somewhere between 25 and 50%.
Okay.
And it depends the reach though, or the impact to members and number of prescriptions, of course, is dependent somewhat upon the utilization and how that utilization aligns with that drug list.
Okay,
You
thank you.
You may have drugs on that list that nobody is taking.
No, it's you, yeah. I get you.
And vice versa.
Okay. So my next, then scrolling just down your presentation, my next question about the medical pharmacy coupon program is, I just really wanted to support member weeks. I do think that 30% seems high. And when I look at specifically slide 9 of your presentation on this, on the enhancements, when I look at the WITH program, I'm assuming, maybe I'm wrong, let me ask that as a question. Is the savings going to be the difference between the 25.25 and the 14.75? So when I'm thinking about UMR earning 30% on savings that this program makes, would that be basically the $1,000 difference between what's listed here in WITH program co-insurance and the employer cost?
I believe it would be the difference between the 3,200, because that's today, and the 1475. So that's the 1725. So it'd be 30% of that in this illustration.
Okay. Okay. So that, I mean, I think that, yeah, that seems very high, especially if it's just, they're just identifying a coupon program, right? This is technology doing most of this. So
they are, I'm sorry, I interrupted you. I apologize.
I was just going to say, I support, trying to negotiate perhaps a lower share of the savings until we do actually see what's being realized and what's being paid through this. I think maybe as a stopgap measure, but so just in support of that.
I'm sorry, I lost sound if you were still talking.
No, I'm
Okay.
sorry. I was satisfied with that answer. Thank you.
Okay, thank you.
And that was all the questions I had. So thank you, Chair Rob.
Okay, thank you. Any further member questions? I can't see the room.
Oh.
There we go. There we go. Any further member questions? Seeing none, we're going to close agenda item 7.1, move back to agenda item 7. And agenda item 7 is for possible action of plan changes.
This is Celestina Glover for the record. So the first change that we're required to make is to the CDHP program plan. The IRS is raising the deductible minimum to allow us to continue to offer health savings accounts. That is $1,600 for the single tier and $3,200 for the family tiers. If we want to continue providing health savings account, that is something that really, although the board needs to vote on it, there's not really an option there other than cancel the HSA. We are not proposing any change to the out-of-pocket maximums. They have a maximum allowed for out-of-pocket, not a minimum, and we're well within that requirement. So that is one of the things we do need to do. And the other thing that is a must do, but you do have 4 options, and that is to align the low deductible and the EPO plans so that we are meeting the Mental Health Parity Act requirements. So those 2 things you can choose or not choose. The recommendation from staff and from our consultants is to accept the renewal from Health Plan of Nevada to continue our HMO. And we know that's going to affect our bottom line. It's going to affect rates. It's going to affect our members, but we're not at a place now where we're considering terminating that contract or terminating that plan. We're also recommending the minimum co-insurance portion of the drugs that are not covered on the Save On SP program. Consider the UMR RX program, and then our recommendation is to not expand the pharmacy. With the other things that are going to increase the cost of the plan, this is the one thing where we believe that this is not a good time to do that. So with that, I will answer any other questions the board may have, but.
Stacey Weeks for the record. So when you said, so I just want to make sure I'm understanding. So no open access pharmacy for now. Specialty copay, are you saying option 1 or 2? Do you have a preference?
This is Celestina Glover for the record. My preference would be option 2. I think that keeps the cost down to the member compared to where we're at right now, and also helps the plan. So we're trying to help both, and that's the option I believe works for us the best.
Okay, any further discussion? Seeing no further.
I'm sorry,
Board
Stacey
Member
Weeks for the
Weeks.
record. Sorry. Thank you, Chair Rob. Can we maybe take these one at a time, or are we doing them all at once? What is the process?
I think taking them one at a time, we will take the motion as you feel comfortable presenting the motion. It sounds like you're ready to make a motion, so
Again.
I'm standing by.
Stacey Weeks for the record. I move to not accept the open access pharmacy network at this time.
Leslie Biddleston, second.
Okay, we have a motion and a second. Any further discussion? Seeing none, I'll call for the vote. All those in favor signify by saying aye.
Aye.
Okay, that motion passes. Do we have another motion?
Betsy Strasburg, like to make a motion to accept option 2, which is the recommended option for the specialty copay.
Betsy Aiello, I'll second it.
We have a motion and a second. Any further discussion? Seeing none, I'll call for the vote. All those in favor signify by saying aye. Aye.
Aye.
All those opposed? Motion passes. Do we have another motion?
Yeah, this is Leslie Biddleston. I move to accept the renewal of the HMO as recommended.
Do we have a second? Okay, we have a motion and a second. Any further discussion? Seeing none, I'll call for the vote. All
I'm
those in
sorry,
favor-
I didn't hear who seconded.
Jennifer McClendon.
Thank you.
Okay, I'll call for the vote. All those in favor signify by saying aye. Aye.
Aye.
All those opposed? Motion passes.
This is
Do we-
Betsy Aiello, and I move to select option 4 for the MHPAEA compliance process.
Second, Betsy Strasburg.
Okay, we have a motion and a second. Any further discussion? Seeing none, I'll call for the vote. All those in favor signify by saying aye.
Aye.
Aye. All those opposed? Motion passes.
This is Betsy Aiello. Do we need to make a motion on raising the IRS requirements for the CDHP? That's just occurred.
This
Need a
is
motion?
Celestina Glover. It's best to just go ahead.
This is Betsy Aiello, and I move that we increase the deductible as required by the IRS for the CDHP plan.
Leslie Biddleston, second.
We have a motion and a second. Any further discussion? Seeing none, I'll call for the vote. All those in favor signify by saying aye. Aye.
Aye.
All those opposed? Motion passes.
This is Betsy Aiello. I guess this is a question which we've gone past, but can we make a motion that would suggest that we do the UMR RX coupon program, but to direct PEB staff to negotiate a more favorable administrative fee? If possible, can that be made that way, or? I don't know. I
I'm gonna
mean,
look.
it's a negotiation, so I don't know. That's why I think everyone jumped over that one. We don't know.
Yeah. Oh.
This is Brandy Mooneyhan, Lead Insurance Counsel. I welcome input from the Attorney General as well, but I believe you can make any motion that you want that's within reason. But if you make a motion for PEB to negotiate and then it doesn't have the result that you like, you may want to structure your motion in a way that perhaps brings it back for the board's consideration.
That makes it much harder. This is Betsy Aiello for the record. That makes it much harder. So I guess I can't have that. But I appreciate what you're saying.
Okay, do we have a motion?
So this is Celestina Glover. Obviously, the board can decide to go with the program the way it sits right now. That would be the motion. If you are uncomfortable with it, you could make the motion to not approve the program.
Miss
rather than
Betsy Aiello,
negotiate.
or we could make a motion to ask you to do a further negotiation and bring it back in to the January meeting. This is Betsy Aiello, and I move that we will request PEB staff to do further discussion on the UMR RX coupon or further negotiation on the UMR RX coupon program and bring that back to the January meeting, any outcome from that.
This is Stacy Weeks. I second that motion.
Okay, we have a motion and a second. Any further discussion on the motion? Seeing none, I'll call for the vote. All those in favor signify by saying aye. Aye. All those opposed? Motion passes. Member Kelly.
Thank you, Chair Rob. Michelle Kelly for the record. I wondered whether the AG's office had a question about agenda item number 5, and I wasn't sure if you had seen that and if we needed to circle back.
I have seen that. As soon as we close agenda item 7, are we done with everything that we need to do on agenda item 7?
Yes.
Okay, now we will close agenda item number 7. At the request of the Attorney General's office, we are going to go back to agenda item 5. And there's a request to clarify the motion. So I'm going to ask, we opened agenda item 5. I'm going to ask for a clarified motion on agenda item number 5 as to what we are directing staff to do in relation to agenda item 5, and then we'll re-vote on that.
This is Leslie Biddleston. Can we have the court reporter read back the motion to refresh our memories?
I can do that, but it's going to take me a while to go back and try to find it.
This is Stacy Weeks. This is Stacy Weeks. I think I messed up on that one. I kind of went blank on what we were doing too. So I made a motion and I didn't clarify. The motion is to continue the negotiations and bring back to the group the contract proposal for approval or, for decision.
In January, yes.
Can I make a friendly amendment to that?
Yes.
I think we need to make it clear to bring back to continue contract discussions for the proposal for the Center of Excellence Travel Concierge Program and bring it back to the committee.
Does the original motion maker accept a friendly amendment?
Yes, this is Stacy Weeks.
Okay, with that understanding, can I get a second on that?
Leslie Biddleston, second.
Okay, so we have a motion, we have a friendly amendment, we have a second. Any clarification or discussion on the motion on the table? Seeing none, I'll call for the vote. All those in favor signify by saying aye. Aye.
Aye.
All those opposed? Motion passes. We will close agenda item number 5. And we are going to move on to the agenda's going to get a little screwed up here for a minute. I'm going to move on to agenda number 9, and we will do 8 and 10 together because they both work with UMR. So let's go to agenda item number 9 at this point. Acceptance of Claim Technologies Incorporated audit findings for the State of Nevada Public Employee Benefits Program, third-party administrator, Value Benefits, WTW for period July 1st, 2022 through June 30th, 2023. Claim Technology Incorporated for possible action.
Good morning. For the record, my name is Joni, Joni, Amato, Amato. The scope of the Value Benefits audit included all HRA claims processed during the period of July 1, 2022 through June 30th, 2023. The HRA claims paid during the audit period totaled approximately $18 million and included approximately 218,000 transactions. The Value Benefits HRA audit included the following components: an annual operational review and performance guarantee validation, a random sample audit of 200 HRA claims, eligibility verification, which included obtaining data from LifeWorks, which is now known as TELUS Health. In our auditor's opinion, Value Benefits showed improved service from the prior audit period and exceeded all of but one of its 2023 performance guarantees. While only one financial error was cited in the random sample audit, the error was large enough to drive the financial accuracy performance below the guarantee metric of 98%, and a $10,000 penalty is owed PEB. CTI noted a substantial improvement in VIA Benefits customer service speed to answer performance from prior audit periods. We recommend reviewing the financial error identified in the random sample audit to ensure that root cause has been identified and claim processor training or coaching has taken place. So does anyone have any questions about the VIA Benefits report?
I can't see any questions. Okay, thank you for your presentation. I'll bring it back to the board. Agenda item number 9.
This is Leslie Biddleston. I move to accept the audit findings as presented.
Second, Betsy Strasburg.
Okay, we have a motion and a second. Any further discussion? Seeing none, I'll call for the vote. All those in favor signify by saying aye. Aye.
Aye.
Opposed? Motion passes. We will move back to agenda item number 8. Acceptance of Claim Technology Incorporated audit findings for the State of Nevada Public Employees Benefit Program Third-Party Administrator UMR for the period April 1st, 2023 to June 30th, 2023 for possible action. Claim Technology Incorporated.
On the record, this is Joni Amato. So the scope of the audit included all claims processed during the period of April 1, 2023 through June 30th, 2023, and included both medical and dental claims. The medical and dental claims paid during the quarter 4 totaled approximately $57 million and included approximately 188,000 claims. The audit included the following components: a quarterly performance guarantee validation, 100% electronic screening with 50 targeted samples, a statistically valid and stratified random sample of 200 claims, data analytics, and the audit also included an annual operational review and eligibility verification incorporating eligibility data obtained from TELUS Health. In our auditor's opinion, the financial accuracy and overall accuracy improved this quarter, but we did not see an improvement in the claim turnaround time. Both the performance guarantees for both financial accuracy and overall accuracy were met, but the 2 performance guarantees for claim turnaround time were not met. This results in a penalty of 2% of the administrative fees for the quarter, or $25,887.16. We recommend that the financial errors identified in the random sample audit are reviewed to ensure that root causes have been identified and any claim processor training or system corrections that need to take place have been made. Similarly, we recommend reviewing the electronic screening and targeted samples results to focus in on potential opportunity for recovery or just improvement in the systems itself. We also recommend that PEB review the eligibility verification results to determine if there improvements can be made in the workflow in order to reduce any payments for ineligible members. So any questions regarding the UMR report?
Any questions from the committee? Board Member Kelly.
Thank you, Chair Rob. Thank you for the audit. And I guess I just heard you say kind of one of the improvements that could occur is PEB could review the workflow to look for inefficiencies. I think that obviously we've been working with UMR now for almost 2 years because they came on for implementation purposes and I think in January of 2022. So we're kind of 2 years into this relationship, even though they've only been paying claims for 18 months. So I just wonder Oh, I'm sorry about that nasty echo. I think someone's got their mic open. I wonder if there's other recommendations that you have that you could make that would help us help UMR get this right. You know, I mean, I think ultimately we all, UMR, PEB, the board, we want, you know, obviously we need these metrics to be met because it's providing service to our employees. And when they're not met, the services to our employees get impacted. And definitely, I think the metrics around, especially our providers, getting paid in a timely manner and in a correct manner is really important, because we do have some very small work centres where if a provider says, you know what, I'm not taking new patients until you resolve this issue, it really has a significant impact on our population. And when our population are impacted, you know, they use sick days, they can't work. You know, ultimately, we want everyone to be healthy and at work, I guess, unless they're on annual leave. So you know, pointing back at you, are there other recommendations that you have that could help, you know, us manage and assist UMR in getting these things right?
Sure. This is Joni Amato. I look back at the year in total, because even though this was fourth quarter, I looked at, you know, the errors throughout the year to see if there's something that's repeated. And I think maybe taking some of those issues that we see repeatedly, we see some provider discounts not being applied appropriately, and maybe or look at a remediation plan. How do we fix these? You know, ask UMR to look at these and provide feedback on how did these errors occur and how are they remediating that to continue to stop that from happening in the future. Earlier in the year, we met with UMR to talk about duplicate claims, because we had seen a lot in the electronic screening, and they've been implementing some system changes to help remediate that problem. So I think some of that type of activity and some of the other categories would be beneficial.
Okay, thank you. Any further board member Weeks?
Thank you, Chair Rob. The only question I have, and it says fees at risk, and I see it's 1%. Is that 1% of their total contract year payment? Like, what is that 1% exactly of? Sorry, I'm kind of new to the contract.
This is Joni Amato. I'm sorry, like the 1% penalty?
Yes, what are we 1%?
It's 1% of the administrative fees that you're paying UMR.
Okay, thank you.
Sure.
Okay, any further questions or discussion? Seeing none, this is an action item.
This is Leslie Biddleston. I move to approve the audit findings for UMR as presented.
Michelle Kelly, I'll second that motion.
Okay, we have a motion and a second. Any further discussion? Seeing none, I'll call for the vote. All those in favor signify by saying aye. Aye.
Aye.
All those opposed? Motion passes. We will move on to agenda item number 10, discussion of possible action regarding UNR performance under contract third-party administrative services. Celestina Glover, Executive Director, for possible action.
This is Celestina Glover for the record. This agenda item was essentially to provide the board the opportunity to discuss the concerns they may have with how things are going with UMR. They've had 4 quarterly audits. They've had some penalty imposed each quarter. And so typically we keep our discussions tied to the audit itself, but I know there's been some concerns expressed to me either by members or board members or providers in regards to the services that UMR is providing. So this is just an opportunity for the board to have a more open discussion about any concerns they have and any direction they want to provide staff or our vendors in relation to going back to taking some additional action outside what the audit has recommended.
Before I go on to Board Member Kelly, I do appreciate this agenda item being on here. And I have a question. There has been audit findings in all 4 quarters, but you as staff, are you comfortable in seeing progress, even though there are findings? Do you see progress and you becoming more comfortable with the process?
This is Celestina Glover. We are seeing that the audits are improving the results. We are seeing movement in a positive direction. I think from my point of view, I'm a little bit frustrated because I want to see it better faster. You know, we've had previous relationships with other TPAs, and this is not the experience we historically have had. And I do know that we get calls from, or letters from providers. We get calls and letters from members that are frustrated because they go to their doctor and their doctor or their dentist, whoever, is coming back and saying, I haven't even been paid for your last visit. And then we get called, why isn't this paying? Is my benefit not covered? And then we need to direct them back to UMR. I know UMR has a process they go through. We've discussed some of those, and I think some of the things in place are necessary, like reviews prior to adjudication for payment. But at the same time, the longer it takes for turnaround times, the more we get calls. It's frustrating for the member and the provider, but there's also more work on staff because QC is doing more appeals. You know, we're trying to respond in a positive manner to address the concerns of everybody. And, you know, I've been asked, how do we make it better? And, you know, I'm trying to come up with some ideas, but I really need some feedback from the board on what they're hearing from the members that they represent. And is there anything specific that you want staff to look at to work with UMR directly?
Okay, this is Chair Rob again. I'm going to follow up. I appreciate that. What do you need out of the board? That's before we get into too much board discussion. How can the board help staff rectify the issues that you see? How can I help you? How can the board help you get to a better spot? That's I want to help you. It's just I don't know how at this point.
Celestina Glover for the record. I think it's understanding specifics that you may be hearing that we can pinpoint, versus we get information, but I know that members talk to each other, providers talk to each other, members and providers may be talking to you. So is there something specific that you've heard that you would like us to look into? Is there some thing that you think maybe we could do differently? We're reviewing it and we're looking at the audit specifically. And then if we get a call or a complaint, or, you know, even if we get positive feedback, typically we don't hear from the people that are happy. We're going to hear from the people that are not happy because something has gone wrong. So I'm really looking for the board's experience, the board's concerns, if any of your members, coworkers, other advocacy groups, I cannot talk, that you may have heard from that have had specific issues of concern that may or may not have come to PEB directly. So it's more of a, is there something specific you're hearing that you can provide to us that we can take that along with what we're hearing to get back with our vendor and say, okay, here's all the issues. We've given time for the board to express their concerns, and here's a plan. Let's develop a plan that we can hopefully resolve the issues that we're seeing. I hope that helps.
And I understand what Ms. Glover is asking, and I hope that all of the board members understand being a board member. We don't have to wait for these meetings to reach out to Ms. Glover and staff to ensure that we are continue to communicate what we are hearing and continue to strive to make things better for our members. So with that, I will go on to Board Member Kelly.
Thank you, Chair Rob. Michelle Kelly for the record, and I appreciate the thoughtful approach to this agenda item. I guess I feel, I guess I would like to request that perhaps this agenda item be pushed to a future meeting. There was significant, there were a number of issues in the South with UMR paying claims. Unfortunately, due to the events yesterday, none of the advocacy groups were able to attend today. And I think that, that started rather early yesterday. And so we didn't even really get public comment from those groups and also the individuals in the South from the NSHE, because I know they have been the squeaky wheels. So I would like to give those individuals and those groups an opportunity. And obviously we have audits every quarter. I know that UMR have spent time trying to address the participant issues in the South. And I do believe that they have put in place some processes that are helping our participants. So I think that, I do want to commend them for taking the time out to meet with UNLV faculty and staff and really looking and listening to the concerns of those groups. As I say, so saying that, the groups were unable to be here today. And just a last comment is that I think that we're probably at the place where we need a remediation plan of some description. I think that UMR have been making strides to improve. So I am, a year in, Q4 of the last plan year, they're still identifying issues. So I think that I definitely have questions for UMR. I'm not sure why it is taking so long to fix these issues, especially since we had a contract with HealthScope who they absorbed. So we're not even, I know that we're a new client because they changed platforms for us, but our plan's not new to the group as a whole. And so I would like to personally hear from UMR to hear their response, maybe in aggregate to kind of the 4 audits. But I also think that staff should perhaps start thinking about a remediation plan. And thank you for the time.
Okay, thank you. This is Chair Rob again. I understand what Board Member Kelly has expressed, and I think it's the duty of this board to work to make things better for our members. So I will work with Ms. Glover to come up with an agenda item for a future meeting, very similar to this one, but also ask UMR to be present so we can ask them questions. It's not agendized for us to ask UMR questions today, but maybe on a future board agenda, we will have something very similar and make it open to ask UMR questions to ensure we are getting better and going forward. Any other board member comments or questions? Board Member Weeks.
Thank you, Chair. I just want to say thank you for the candor. I think it's hard. I mean, I work at the state as well, and I just want to say that I think these benefits obviously are one of the few things that we have to offer our staff, and it's super important. And the money we're spending is their contributions, our state taxpayer dollars. They're limited, and so I really do support holding our vendors accountable. And I just want to be clear on that's my stance. And I also feel to make some of those decisions, if it's available next time we meet, to have more information about some specific concerns about generally maybe some 3 buckets that you're hearing staff know that providers are complaining about, members are complaining about, just to help us be better informed. I mean, I can ask my staff, but I would rather know like what you're hearing as well. And then also thinking about like provider surveys and other things that we've done, if we could see some of that information, that will help, I think, the conversation. That's my only request.
This is Jennifer.
Any further board member comments? Yes. I can't see, you're kind of out of the frame there for me, so go ahead.
This is Jennifer McClendon for the record. I would just like to follow up on Board Member Weeks' comment and say, from my perspective, most of what I hear is that people's providers are leaving the plan. And in Northern Nevada, where we have limited providers, that's a significant concern. But it's hard for me to understand what is anecdotal, like what is someone crying because they've lost their one provider that they love, and what is like a broader issue. So I'm wondering if we could get some sort of report of how many providers have been lost in the last 2 years, maybe broken apart by region. Because from my own experience, hearing members' complaints and experiences when they come to me, that seems to be a bigger issue. I hear about, appeals processes and things like that as well, but mostly people are distressed when they can't use the providers they've been using. Thank you.
Okay, any further comments? This is an action item, and I think the discussion has given staff quite a bit of direction. Do we need to have a motion? Or are you good with, is staff good with where we're at with the discussion, or do you want a motion to wrap up the discussion?
This is Celestina Glover. I'm good with it as long as we're not breaking any rules.
No, this is Brandy Mooneyhan, lead insurance counsel. If the board does not want to take any specific action today, it does not violate the open meeting law. If you do not want to take action,
I couldn't hear all that. I apologize, but what I know is it says for possible action. It doesn't mean we need to take action.
correct.
And I think the discussion has led us to an outcome that we know where we're going to go. So with that, any further discussion on agenda item number 10 before we close?
Hey, Chairman
Seeing
Robbins,
none?
Helmut Braun. Is there any chance I can make a comment here?
No, it's not agendized for UMR a comment, and I wouldn't want to go out of turn at this point.
Fair enough. I understand. Well, I appreciate all the comments that have been made today, and we'll take those into consideration when we respond next time. Thank you.
Okay, yeah, we'll make sure it's agendized so we can get a full interaction with you and your group to figure out how we move forward.
Sounds good. Thank you.
Okay, thank you.
Hey, Rob, this is Radhika Kunal, Deputy Attorney General. If the board wishes to put this matter back on the agenda and at on a future date, maybe that could be a motion. Like I agree with Brandy that because it is a possible action, if the chair or board does not wish to take a possible action on it, it doesn't violate an OMO. However, if you wish to bring this back on a future date, maybe a motion is warranted.
Okay, I would entertain a motion to bring this agenda item back with the additional information discussed during this meeting.
Okay.
Michelle Kelly, so moved. Sorry.
We'll all make a motion.
Okay, so we have a motion and a second to bring this agenda item back with the additional information discussed during this agenda item. All those in favor of the motion signify by saying aye. Aye. All those opposed? Motion passes. We will close agenda item number 10 and move on to agenda item number 11. Public comment. Public comment will be taken during this agenda item. Comments may be limited to 3 minutes per person at the discretion of the chairperson. Persons making public comment need to state and spell their name for the record at the beginning of their testimony. Do we have any public comment in Carson City?
Good afternoon, Kent Urban, ERPIN, Nevada Faculty Alliance. I have several items I want to address related to today's meeting. First, the contract report was in the board packet under agenda item 5, but the usual discussion was not agendized. I had a question about the VIA benefits contract, which the question was raised last time why VIA benefits was not listed as a contract. And we were told it was a no-cost contract, but when it does show up on the list, it's a $1.5 million contract over time. So certainly I would have hoped the board would have asked about that, but it wasn't agendized. So maybe we can get a contract report on that at another time. Regarding the increase in the deductibles for the high deductible health plan per IRS minimums, of course, that's something we have to do, but that's a higher cost for participants. And to keep the plan value and benefits the same, there ought to be an offsetting benefit change, either an increase to the HSA contribution or some other change. Now, you know, the $100 difference maybe, or $100 to $200 difference isn't huge at this point, but over time that will move the benefit design of the program. And so that's something that really ought to be discussed in terms of policy. You shouldn't, since it's the minimum, probably the policy should be that it's at the minimum, then you wouldn't have to have a board motion just to raise it to what you have to do anyway, but also to have a formula for what else happens with the program. We move forward to the rate setting in, I presume, March. In the policies and procedurals document for PEB, it states that the employer contributions, the state subsidy, are identical across all three plans in each tier. But in fact, in last year's, in FY23 and 24 rates, that's not quite true anymore. The employer contributions were adjusted in a different way to make the premiums not vary at all. But so that's going against your own policy. And I see no reason not to keep that policy because it was put in for a reason, and that was to be fair to all participants across all plans by providing them the same employer contribution, and then participants choose to pay the differential cost for a different various plan. The differentials are not huge now, but particularly with the HMO increases, they could get larger, and so that needs to be addressed. Finally, and this is related to the conversation about UMR, and I appreciate you bringing that back and allowing our UNLV colleagues, Southern Nevada colleagues, to chime in on those issues, which have been raised more down there than in the north, although there are also issues in the north. I would say that it's also PEB's responsibility to respond to issues and complaints. And what we've seen, and I've heard from constituents over the last period of time, is we don't feel like we have anyone we can go to at PEB anymore. It used to be that if you needed to escalate an issue, the quality control officer was the person who had your back, who you could talk to, who would work with the various entities and deal with the problem and help get problems resolved for your members. Now that's become a very kind of impersonal process. You get an email back that's not even signed by a person, just says from quality control. The member we heard from today has had similar experiences. And so my question is, well, who are we supposed to go to for help when there is a situation that a member needs help to go between UMR, the provider, and PEB, and figures being pointed in various directions, and they're just at wit's end. And then there needs to be somebody to go to at PEB who would really care and give help that member. Thank you.
Thank you for letting me approach you again. My name is Kelly Osborne, Kelly Osborne. Just to follow up with what Kent was just saying, I'll give you for instance, what happened to me in October when I came into this came into PEB to talk to somebody about the transplant procedure. I asked the quality control officer if I could meet with him in an office. I was told no, I had to meet with him in a open room where there were members of the public available, sandwich vendors, people meeting with their other staff. I wasn't even given an opportunity for a private conversation. I just feel like I've been dismissed. You guys are better than this. You guys want better for your members. I trust that you guys will keep our interests at heart. Thank you.
Hello, Tessa Opperman here on behalf of the AFSCME retirees. I will keep this brief, but I just want to echo the concerns that we heard from the last two public comments. I know that the retirees have similar concerns and oftentimes ask for kind of a point person that they can go to with questions, concerns, especially when we're dealing with retiree populations. They don't necessarily know how to, navigate online systems or navigate communication bases that way. And so I just want to echo that because I think it is important. And I know they specifically have asked for some sort of point person within PEB that can help them, like I said, an ombudsman of sorts, but can help them navigate complaints and be a person, an actual number they can call, email they can email. That's not just a complaint system online. So thank you for that.
Chair Rob, that is all the public comment we have in Carson City, and we do not have any virtually. Jack, we can't hear you right now. Chair Rob, we cannot hear you right now. You're on mute. Apologies.
So sorry. We close agenda item number 11. We're on to agenda item number 12, which is adjournment, and we will stand adjourned until the next meeting. Thank you very much.